and welcome to Brewing Brilliance, a podcast where we talk to academics from across the university who are involved with the Healthy Ageing and Chronic Conditions Research Institute. We will be speaking to researchers who are leading innovative interdisciplinary approaches to promote lifelong health, delivering improved interventions to manage chronic conditions more efficiently. These sessions are essentially opportunities for us within the Healthy Ageing and Chronic Conditions Research Institute to meet colleagues from across and beyond our faculty to foster knowledge sharing, collaboration and networking. My name is Adrienne Cleverly and today we are joined by Dr. Becky Thomas. Dr. Thomas is a senior lecturer at Swansea University Medical School, where she teaches on population health and diabetes and is a co-programme director for the MSc Diabetes Practice. Dr. Thomas has participated in international outreach programmes, developing screening programmes for diabetic eye disease, demonstrating her commitment to global diabetes care. In 2021, Dr. Thomas received multiple accolades at the Quality in Care Diabetes Awards. She was also recognised for her role in Diabetes 101, a collaborative initiative aimed at supporting individuals with diabetes through social media during the COVID-19 pandemic. Welcome and thank you for joining us.
Thank you for having me. Thank you for the invite.
It's lovely to have you here. So, first of all, I'm going to start with a nice easy question. What sparked your interest in diabetes but then led into eye health?
So I've got a really strange history with it all, but I finished my undergrad degree, which was marine biology, so it's completely unrelated. And I'd come home not knowing what I was going to do. Like I still had no idea what I wanted to be, is what everybody keeps asking. But at the time, it was 2003, and in Wales, well, large amounts of the UK, they was just setting up their national screening programs for diabetes, for diabetic retinopathy, for eye conditions. So there was a big drive to get in a lot of staff. So I thought, eyes, and diabetes is a good condition. I might went along for an interview, and I got the job and I became a grader within our national screening program in Wales. So I saw it right from the start, the day it became a national screening program, all the way through till I left in 2007. So I was a retinal grader. So I looked at all of the eye photographs that we take, grade them for diabetic retinopathy, and then decided at which point they needed referral or whether they needed to stay with us and just keep coming back. So in Wales, up until 2023, we were screening everybody annually. So everybody came in after the age of 12 when they were diagnosed with diabetes, and had photographs taken. And yeah, that sort of sparked the interest. And then I left in 2007 to start my PhD, which was looking at how often we should screen people, because people forget that screening can be harmful. So it creates health anxiety. So every time you call somebody in, you are stressing people, you are creating this anxiety. So if we can do it less frequently in some people, more frequently in others, you have a better balance of that risk benefit that we're all striving for, and a more cost-effective program. But so that sort of launched me into the world of diabetes and eye health.
And now you've got this wonderful sort of script of what you've done and accomplished in that time for the different programs you've been involved with.
Yes, yeah. So yeah, it all started with the Welsh program, and I think being there from ground zero when they first setting it up to rolling it out nationally, it was a really amazing experience. And then I've had experience of working in the Gloucester program over in England, and that was great, run very similarly, but and then my research experience has sort of taken me globally and across the world. So I've was very, very lucky when I was doing my PhD. We were invited to Mauritius, and they were just developing their national service frameworks for diabetes and how they should treat. And one of the things we set up over there was originally a regional screening program for diabetic retinopathy, and then developed that into a national screening program over 5 years. So whilst doing my PhD, I was back and forth to Mauritius
It's not a bad way to go, is
It
it?
really isn't a bad life. I can't complain. And then once we finished there, we were then invited to go to Trinidad. And in Trinidad, we developed we had a pilot and then a regional program. We did have money or we were promised to take it nationally, but unfortunately, it was a change in government. These things always go in cycles. But after Trinidad, we started looking at what we could do in Peru.
Gosh.
Couple of years ago, we were in Bermuda, and we've started looking at what their population needs and how we might help them develop their program. And then last year, I was really lucky, and it was really impactful. Actually, I was invited to Tanzania to go over there and see what we could do, what we could help with, how they need to go forward. We started collecting some data around screening, which we then used to push for them to get their first laser treatment centre over in Tanzania.
Has all this experience that you've had with travelling across these different countries and working under different government guidelines and things like that influenced the way you shape your research?
Yeah, I mean, I think when you have this ideal view of the world when you first start out, and like the Welsh model of screening and, the other UK nations, it is envied quite a lot, because even across Europe, most countries don't have a national or established screening program. There are a few pockets, and they might have a regional program there or here or there, but the UK really has pioneered the national screening program structure. But when you go to different countries and you see, you can't just take what we've got and put it into their setting. You really have to look at what their population needs, what's already there, what training everybody's got. And you really have to remember that sort of screening is great, but if you can't treat, there is no point in screening. So, you have to do those balances, and you have to really look at what the population needs to start off with, because if they can't access insulin, which many countries can't still, then treating complications isn't there first and foremost in the.
It's not a priority, is it?
Really
Because
not.
they're just telling people. That's bizarre. And you forget as well, don't you? Because you sort of focus on your little niche and your little area and your needs, essentially.
Yes.
And then you forget that there's a whole other world out there with different...
Yes, yeah, and in the UK now, we're so lucky and fortunate in diabetes. We've got all of these new drugs. We've got all of these new technologies that are coming in with continuous glucose monitors and hybrid closed loops, and they are brilliant, and they are really helping people not just improve their outcomes or the complications that are around diabetes, but they're really improving quality of life, and helping people to manage their conditions and sleep. People are actually being able to sleep for the first time. So if you can imagine a parent of a child with type 1 diabetes,
Yeah.
and they're up all hours of the night checking, finger pricking, checking blood glucose levels to make sure they're not going low overnight, to make sure they're not going high overnight, and then waking the child up to sort of treat whatever they see. But now we've got hybrid closed loops that sort of keep everything stable overnight, and parents are actually for the first time able to sleep.
And it's again one of those things that you sort of don't necessarily think about, isn't it? And like the impact of sleep, that's like one of the huge things you just mentioned. Living well, being able to sleep is a huge part of that.
Oh, it affects everything, doesn't it? If you don't have proper sleep quality, I am a very grouchy person if I'm not sleeping very well. So, and it impacts your ability to think and make it through the day, function properly. So, yeah, I think when the trials came out with hybrid closed loops, that was one of the things that really did impact me. One of the outcomes was parents saying they could sleep for the first time in 10 years.
And that wasn't one you were expecting, I'm sure. No.
No. And, in all these trials, we're always focused on glycemic management and what is the HbA1c outcome. But I do think those quality of life impacts are just amazing to see.
So we've touched a little bit on some of the big things that you've done. Can you tell us at the moment what research you've got going on at the moment?
We've got quite a few projects running at the minute. So most of my research at the moment is focusing on health services research, so around the ophthalmology and optometry practices. In Wales, we've got big changes coming in that a lot of work is now going to shift from hospital-based ophthalmology centres into our primary care-based optometrist practices, because our optometrists are really skilled and we're very much underutilising what they can do for us. And we don't have as many ophthalmologists as we should have. And so our services are really, really struggling. And the new treatments that we've got coming in, so we've got new anti-VEGF injections. They're brilliant, but people need follow-up really closely. So then that places strain on the services and increases waiting lists.
Yeah.
And I think there was I think somebody published last year that around about 27 people every year in the UK are losing their sight while sitting on a waiting list, which I think is just...
And we've got skilled people that are able to help combat that.
Yes. Yeah. If we can just shift out some of the intense monitoring into our community practices that have all of the cameras and the OCTs and, maybe a bit more time, and leave ophthalmologists for when treatment is actually needed, it just shifts everything around and it's more comfortable for patients. If you don't have to go into a hospital and you can go into your more familiar optometry practice.
And it touches on what you said earlier about reducing that stress and the anxiety around attending appointments, and it's quite a cycle, isn't it?
It really is, yeah. So we've been really lucky. We've got this whole sea change in Wales where Welsh Government has really recognised what optometrists can do, and so they are pushing for this change, and they've just funded for us now a Centre for Vision Services Research in Wales. So that's based in Cardiff University. So our director, Barbara Ryan, at the School of Optometry in Cardiff, is running that for us. And then I'm involved from the Swansea angle and bringing in our sale data as well to try and help. But that's all focused around transforming eye care services in Wales, helping those people who have experienced sight loss, helping them to live well.
Do you have that sort of, because you talked about, so we've got the collaborative connection in that sense, but do you also have like public engagement or patient involvement? What does that look like?
Yeah. No, public patient engagement is really, really vitally important. We bring in every grant application that we do, we make sure we've got the voice of the patients that we're trying to help. So we've got public reference panels that we can go to, we can take ideas to and chat through, the research that we want to do, make sure that it's important to them, but we can also go to them to get the ideas. So, what's not working well for you? Where are the issues sitting and how do we work at solving those sorts of issues? So for us, public involvement is key. And within the centre in Cardiff University, we do have a public engagement person who sits with one of our third sector charities with Sight Cymru. So we're working in collaboration all across Wales. So that centre only started up in April this year.
Oh, wow.
So we got Health and Care Research Wales funded it. So it's a £1.8 million investment into changing eye services in Wales, which I think is amazing and is really, really needed.
Yeah, and we touched a little bit on like diabetes and eye health. Are you able to talk a little bit more about the link between the two and why it's so important, especially sort of as people are aging?
Yeah. So as everybody ages, their risk of developing an eye complication increases, as with every other disease and condition. But with diabetes, the longer you live with diabetes for, the more impact it has on all of your organs, including your eyes. Because hyperglycemia in diabetes, it's the blood flowing through every single organ in your body. And as it goes through, you've got this high glucose level that is then damaging the structure. So it's damaging the eyes. So the statistics are that if you have type 1 diabetes, for 20 years, 90% will develop some level of diabetic retinopathy. So that's the condition that really that's caused by the diabetes that can cause sight loss. Um, after that 20 years, so if you're looking at the sight threatening levels, it comes down to about 30% of people are likely to develop the sight threatening levels and to need treatment.
And it's interesting as well because like diabetes is one of those conditions where you can you have that association, if you will, with sight loss, but you need your eyes with a condition like diabetes.
Oh, very much. Diabetes is such a visual condition.
Yeah.
You've got to think about, especially if you're on insulin, you're looking at your glucose numbers, you're looking at the amount of insulin that you need to put in your pen or your pump. You've got to look at carbohydrate numbers on food packaging. So to lose your eyesight or even have it impaired really affects the way that you manage your diabetes, which then impacts on other conditions that you're likely to get if you're not self-managing as well as you can be or should be. So it's crazy. So then if you look at the numbers for type 2 diabetes, it's slightly less than type 1. So after about 20 years of living with type 2 diabetes, about 60 to 70% would have some form of retinopathy, and about 20% would have the sight-threatening forms. So, the longer you have diabetes for, the more risk you have for sight loss and for...
Which is why having all these things that you've discussed at the start of this is so important.
Yes, yeah, and screening comes into that because the best thing you can do for your eyes is manage your diabetes if you have diabetes, or, eat a healthy diet, wear sunglasses, all of these things that we're always told. But diabetic retinopathy is you don't have any symptoms of it until it's quite late on.
Oh.
And once it's quite late on, the treatments that we've got, some of them are destructive in itself, but if you've already got sight loss, we're not looking at bringing that sight loss back. You're looking at trying to prevent it getting worse as opposed to restoring vision. And so the earlier that we can intervene, the better the sight outcome is. So this is why we need screening to pick up on the changes as early as possible. So you can make changes to your diabetes management if that's what you need to do. Or B, we can start treatment the very second it's needed, and so that you don't lose any sight.
You can reduce that risk of that. It's crazy. So on that note, we've talked a little bit about where you've been with your research. We've talked about what you're doing with your research. What's brewing next for you? Is there anything? Is there?
Yes. Yeah, we've got so much ongoing. So, I briefly touched on the centre that we've had funded, but we've just finished several projects that we're looking at how we can bring our minority ethnic groups into screening in diabetes, because we find that within those populations, they are more at risk of developing diabetes, but of having diabetic retinopathy as well. So there is a bigger risk. And our screening programs are set up for the general population. And if it's not set up for the way that you work or that works for you, you're not going to come into screening. So we're trying to work out ways now that we can really get those other populations engaged that our current system isn't set up for. And that program has really found that language is a big barrier. We assume that even if somebody can speak English, that they will understand everything that we tell them. And through that project, what we found was that having somebody there translating at the time with you is even more impactful, because they really do understand then what you're saying.
Yeah.
It's not just an assumption. And so that was a big outcome.
And it kind of touches on what you've talked about as well, because if you've got that language barrier, again, you increase in the stress and the anxiety again. So it just goes.
Yes. Yes. Yeah.
They all sort of interconnect in some way, don't they?
They really do. And then we've got programs then to look at. So currently our laser technology is all done by ophthalmologists, so our consultants, our doctors, but we've now got some new laser technology, which means that we might be able to train up some of our optometrists, our ophthalmic nurses, to try and do some of that laser so that we take that away from the ophthalmologist and they can concentrate on the surgery and other things that they can do. We already use, our ophthalmic nurses already run our anti-VEGF services. So this is sort of expanding that kind of role. But beyond the health services work that we're doing, there is a big explosion at the minute in artificial intelligence. And, it's the buzzword, isn't it?
Yeah.
But
especially in research.
yes, yes, especially in research. So, and the promise of artificial intelligence, whether we'll reach it in the next 5-10 years, who knows, is that we'll be able to take the retinal photographs that we take every day in screening, and we'll be able to tell your 5-10 year risk of developing other health conditions like cardiovascular disease and stroke or dementia, or in diabetes, neuropathy and nephropathy. So it'll, from one eye photograph, it can tell you so much more about what's going on in the rest of your body. And if you have that information, you can start making the changes to your lifestyle and everything else to help prevent that. And hopefully we can develop more treatments.
And like you said, get it sooner, because eye health is so important, but it's something that if you don't need it, you don't necessarily seek it out, do you? But it can pick up so much.
Yeah, you can see an awful lot from the eye anyway. We can look at the eye and think, oh, there might be some hypertension. There's so many other conditions, and we're all at risk of developing eye health conditions. And you're right, we don't think about it until a problem occurs. But this is why we have to go for regular eye checks. So up until the age of 60, I think it is, you should go for your eye to your optometrist every 2 years. And people don't think about this. This is just to make sure that we are looking at things in the right way, and and they can check so much in your eyes, and it just gives you that reassurance that everything's okay.
Yeah. And stuff you take for granted as well, isn't it?
Yes.
If you could, maybe a silly question, I'm sorry, but if you could bust one myth about diabetes or eye health, what would that be?
So the biggest myth in diabetes is that having diabetes means you will go blind. I think that is quite a big thought for a lot of people. I don't want diabetes because I don't want to go blind, or it's a lot of the time used to try and get people to manage their diabetes better. You have to manage your diabetes or you will lose your sight. And it's not that. It's not at all. Diabetes is a preventable form of sight loss. We can reduce your risks. Yes, self-management is really, really important. And if you manage your blood glucose levels and your blood pressure levels, you can really reduce your risks of developing diabetic retinopathy and then, losing your sight because of it. If you attend your screening appointments, we can pick it up when it needs treatment. And the treatments are really, really good if they're used at the right time. So there are a lot of things we can do to prevent sight loss. So that's my biggest thing, is that diabetes does not equal sight loss.
And that's a big common myth then, I'm assuming.
Yes.
And also go for an eye test even if you don't need one.
Yes, always go for your eye test. It's like your dental appointments. You should go for your eye tests every 2 years or every year if you have diabetes.
And we've got wonderful people working on the programme, so,
yes.
Go see them. Do you know, that was so interesting. Thank you so much for coming in to talk to us. If you would like to find out more about this research, they can get in touch with you at your staff.
Yes.
Yeah, brilliant.
Yeah, definitely.
So you can reach out to Becky at her staff profile at Swansea University, or you can reach out at us at the Healthy Aging and Chronic Conditions Research Institute. Thank you so much for coming in. That was so interesting.
Thank you for inviting me. It's been brilliant.
Thank you.